He will give talk on cardiac CT beyond coronaries, focus on structural heart disease.
Friends, ladies, colleagues, and gentlemen, it's a great pleasure to be back here in Bangladesh once again, and I must thank Mohsin for inviting me to this wonderful conference. Can I have my slides? Oh, very good. So, advances in imaging are changing the way we treat patients, and perhaps the organ which has seen the impact of advances in imaging the most is the heart. The advent of cardiac CT and cardiac MR have changed the imaging algorithms for almost all heart diseases today. And no heart disease is better placed to gain advantage from these advances than the structural heart diseases. Why CT? We know CT, the famous cousin of cardiac CT is the CT coronary angiography, but believe me, the bigger impact that cardiac CT has made has been in the imaging of structural heart diseases. Why is it so? Because as you can see here, these images will show you these are two examples. I don't know how. Oops. Can I use the pointer? Yeah, very good. So you can see the exquisite detail of aneurysms in Kawasaki to an absent pulmonary valve. That's the kind of anatomy that you can see in current generation CTs today. Why is it so? Because of the remarkable temporal and spatial resolution, our ability to actually acquire the 3D data sets in real time and reconstruct in any plane. And the best part is, today we can do it in single breath hold, and actually in many of these patients, you don't even need a breath hold. And that's where the impact of CT is most obvious. So let's try and see how CT can be useful in various diseases in the heart. In terms of congenital heart disease, whether it is the assessment, beginning with the assessment of situs, to looking at the connections, the systemic venous, the pulmonary venous, the relationships between the various cardiac chambers and the great vessels, or to the coronary artery anatomy, to the anatomy of the lungs and the airways, cardiac CT has it all. You can see some excellent examples here. You see the exquisite detail of coronary anatomy. The best part in cardiac CT is, you see, when we do cardiac angiographies, catheter angiographies, we are doing a two-dimensional study. Unfortunately, we can only see the chamber which is opacified. In a cardiac CT, you can see the spatial relationship of the coronary artery to the adjacent structures. You can clearly see an anomalous coronary artery crossing over the right ventricular outflow tract. What is in the realms of imagination in a catheter angiography is an objectively defined structure in cardiac CT. That's why this investigation is becoming the one-stop shop for examination of almost all structural heart diseases today. Let's look at all these issues one by one. So in terms of assessing the situs, whether it is the abdominal situs, relationship of structures within the abdomen to each other, whether it is the sinoatrial situs, in other words, relationship of the cardiac structures to the abdominal structures, or whether it is the tracheobronchial situs. All of these can be analyzed in a very objective manner. In terms of assessment of systemic venous anatomy, you can see here whether it is a single SVC or a bilateral superior vena cava, whether the communicating vein is present or absent. These you would have to put in a catheter, inject dye, and examine. These can be seen at a glance. Now, when you use these images, so it doesn't matter whether you use the CT or MR or echocardiography or catheter angiography, in terms of clinical decision making for management of congenital heart disease, there are certain questions that you need to answer. The first of which is there a two-ventricular repair possible or not? So are we going to look at a univentricular or a biventricular intracardiac repair? And this depends on whether there are two functional ventricles or not. What is the morphology? Is it the RV morphology or the LV morphology? Both of which can be very clearly identified on a routine cardiac CT today. The second important thing in decision making in cardiac CT is, or in terms of management of congenital heart disease, is the presence or absence of confluent pulmonary arteries. That's the first step. The second important step is how big are they? So that will decide whether I would do a single stage repair or a two-stage repair. And cardiac CT as you can see here, today is the gold standard investigation for demonstration of pulmonary arterial anatomy. The confluence, the sizes, the presence of stenosis, as well as differentiating the aortopulmonary collateral arteries from the native pulmonary arteries. That's an important question which is often not very well answered on catheter angiographies. The next step in terms of clinical decision making for congenital heart disease is to define and identify all the 4 cardiac valves and assess their morphology as well as function. Now, cardiac CT is perhaps the best way, superior to echocardiography, to define the morphology of the AV valve or the semilunar valve. As you can see here, you can see a classic, what is called as a fishtail, appearance of a bicuspid or a aortic stenosis, mitral valve, tricuspid valve, or the aortic valve. These can all be very well defined on cardiac CT. The limitation of cardiac CT here is that it is unable to assess as of today the functional abnormality in the cardiac valve. In other words, the regurgitation or a palavalvular leak cannot be detected on a cardiac CT. That's where cardiac CT and cardiac MR are very complementary to each other. What is the limitation of a cardiac MR is the strength of cardiac CT. What is the limitation of cardiac CT is the strength of cardiac MR. Between the two, these orthogonal imaging techniques are the way to go to evaluate the heart irrespective of what the disease you are investigating. Coronary anatomy I have alluded to in detail actually, as you can see here today. For assessment of coronary arterial anomalies, for assessment of proximal coronary artery obstructions, cardiac CT is the gold standard investigation. Moving on, the next step that you need to answer in terms of deciding the management strategy for a congenital heart disease is the assessment of pulmonary venous circulation. And as you can see here, whether it is normal, whether there is a partial venous anomalous drainage, or whether it is a complete or a total anomalous pulmonary venous connection, these are very well demonstrated on a cardiac CT. The ventriculo-arterial relationships, in other words, whether the ventricle is connected to the right great artery, like for example in this case, this is the ventriculo-arterial discordance. The demonstration of intracardiac defects can be objectively and reproducibly. That's where it is important. Echo can do the same, but it is not reproducible because it depends on the individual who is doing it. In terms of cardiac CT, this is independent of observer. That's what is important. Then the intracardiac, for example here, now the demonstration of the aorta and the pulmonary artery above tells you immediately that this is a complete transposition of great arteries. In other words, what I am trying to tell you is the spatial relationships of various structures is best demonstrated by an orthogonal imaging technique, and cardiac CT is the best example of that. When you move out of the heart, you look at the aorta or the pulmonary arteries, the various aortic arch anomalies. Today, our understanding of vascular rings has changed dramatically with the advent of orthogonal imaging techniques. Whether it is the aorta or whether it is the pulmonary artery, as in this case with a pulmonary artery sling, entrapment of the airway between the abnormal placed pulmonary artery, CT angiography is the way to go today for establishing the deformities in the heart. One area where it has made the most impact has been in the evaluation of the postoperative heart. Whether it is after CABG, whether it is after corrective congenital heart surgery, cardiac CT is the best way to assess these abnormalities. The earlier generation CTs had a limitation. The functional abnormalities were not so well seen. But today, as you can see here, it is almost as good as MR is, which is the gold standard today for assessment of the heart function. Now, some emerging applications of cardiac CT include assessments, for example, for TAVI procedures, for left atrial appendage plugging, for atrial septal defect, ventricular septal defect plugging. CT angiography is the way to go to plan these procedures. So my friends, I would stop here to tell you that today the current generation gated CT or MR, both are ideally suited for assessment of the heart abnormalities. They complement each other play upon each other's strengths and weaknesses, and together they are the way to go to assess the structural abnormality irrespective of the heart disease. Thank you so much for your kind attention.
Thank you, sir, for your